and he has been on the podium for n number of refractive and corneal, refractive and cataract symposiums. Over to you, Sandeep.
Yeah, thank you, Nitin, for those kind words, and thank you for this humbling opportunity. When you stop seeing those little drops coming in, you know that you need glasses. And when that comes in, comes that little, I have really no financial interest in any of the technologies or products mentioned over here. So this is your dilemma. You have a patient in front of you, an early presbyo, just not willing to accept glasses. He's just 40 years old. For the first time, he's realized he can't read his newspaper in the morning, and he's coming and bombarding you. He's just there. And you are also in a dilemma because none of the technologies that you have on hand are foolproof. None are permanent, so you don't know what to do. But yet, basically, you need to do something. Now, the first thing is some basic concepts here. We all know that accommodation from the lens is an active dynamic process. It depends on the elastic properties of the lens, which has a high depth of focus. On the other hand, when you're trying to look at the cornea, this is a tissue which is more static, and it has a low depth of focus. So in lens-based options, what you're doing is basically you're sacrificing the natural accommodation of the eye for a pseudo accommodation, which is certainly not as good as the natural accommodation. Remember, at 40 and 41, they may have lost a little bit of accommodation, but they still have some accommodation left. Okay? So here, basically, you're putting a lens which is either going to split light or is going to enlarge the depth of focus. And in corneal-based laser procedures, you're going to play around with the spherical aberration of the cornea so as to increase the focal amplitude. And so these are various options available to you. And today we are going to stick to basically the options of changing the lens or changing the depth of focus, which is basically a Press-B LASIK. Now in Prelex surgery, what can you offer this 40, 45-year-old? Can you go in for monovision with monofocal IOLs, in which the dominant eye is corrected for distance and the non-dominant for near? And we're going to talk about results later. The diffractive IOLs or the EDOF IOLs, and monovision with monofocals. That means you put one eye, you correct him for distance, and you put a monofocal in the other eye, and you correct him for near. Or you may even slightly modify and reduce the amount of disparity by increasing the myopia to about minus 1.5 diopters. However, the biggest problem with monovision in cases of monofocal IOLs, it is difficult to predict where the monovision will work. And hence, I would say to all these patients who are in the 40-45 age group, and if you're planning monovision either by IOL or by laser, the first most important thing is to give him a monovision contact lens trial. Not spectacle vision, but contact lens trial to know whether monovision will work. Because the biggest problem you have in your life is if monovision doesn't work this way or that way, that is out of the way. And remember, it's a contact lens trial. Okay? And of course, you have to explain to them that stereopsis might be lost if your difference increases by more than 1.5. Some people say, other eye, I have to read, you know, and then you have to tell them that if you're trying monovision, you're going to lose your 3-depth focus. Trifocals, all are modern, and I don't want to go in details of this slide. We all know that they have issues with loss of contrast, issues with glare, and halos during night driving. And of course, the biggest challenge in this 40 to 45 age group is that the refraction is going to change over time. Now, all of us know that the cornea keeps on changing very slowly, and right up till the age of 50, though the books say 45, there is some shift in the astigmatism that occurs at the level of the cornea. And over a period of time later on, there is going to be, as your posterior corneal astigmatism increases, there's going to be a drift towards more against the rule astigmatism. So are you going to load in with a lens at this time? And what about the changes that will come later? Will he be prepared to wear glasses then, or he'll come to you for another procedure? The EDOF IOLs, well, whatever type you get an elongated depth of focus. You have better contrast, less glare and halos as compared to the trifocal. However, the near vision in all these cases is often compromised as the addition is low. So what is my indication for Prelex in the 40 to 45-year-olds is individuals with small or early lenticular changes. If I find even if there is a small change in the lens, you know, there is a little bit of cataract, I would put in and go in for a lens-based procedure as compared to changing something on the cornea. And of course, hyperopes. If in all hyperopes, if they have a shallow anterior chamber and there is a likelihood of an occludable angle and they are asking for these things, and if they really insist on these things, I would definitely do a lens-based procedure. On the other hand, let's see what corneal refractive surgery has to offer, because there's a lot of work being generated in this direction. We all heard of central Press-B LASIK, in which the central zone in the non-dominant eye can be corrected for near, okay? So you have this zone which is correct, and this is available on all laser platforms, and a small transition zone, and then the peripheral is corrected for, for distance, and beyond that, of course, is the untreated zone. And then you have another thing which comes from Technolas. This is called a supracore. It creates a hyperpositive area in the central 3 mm zone, giving an addition of approximately 2 diopters. And it can be used either symmetrically or asymmetrically. The Presby max comes from Schwind. Basically, here you're making the cornea genuinely multifocal. There are two kinds of hyperpolate surfaces there, one to correct your distance, one for intermediate, and one for near. And it's probably the only technology with published results in cases of emetropes and myopes. Most of the other technology of Presby LASIK have been published are in hyperopes, and they are, of course, very good results over there. Now, the NIDEC people thought that in all these earlier technologies, since the central zone was corrected for near, it always led to a compromise in the distance vision. So what they thought very smartly is that let's keep the distance vision as the central vision as corrected for distance, and the peripheral zone in the cornea, let's correct it for near. Now, there is a problem here because most pupils are not large enough to accommodate so many zones. Again, in bright light, you are constricted, and when you have bright light, you have meiosis, and you can't read. And the basic thing is that if you were to try and do this in a myo, you tend to eat up a lot of tissue. So that's the problem with peripheral LASIK. Now let's look at a technology which basically believes in altering only the spherical aberrations. And this comes from Carl Zeiss. They have the Press Beyond, which as we know is laser blended vision. The non-dominant eye is made slightly myopic, about -1.5 diopters. And there is an area, a zone of intermediate vision which crosses in both the eyes. Means there is a blended zone, as you can see in the center, which overlaps the two eyes. So that gives you a full functional range of vision. And this can be attempted in emetropic, myopic, as well as hyperopic eyes. Now, unfortunately, I don't own a Technolas. I don't own a supracore. I don't own a Schwind. Okay, but what do I have? And what would I do if this patient comes to me? And this is what I tend to do. This is the custom tube. Now, remember this diagram very well. Basically, in the center, you have the pupil outlined by the brown ring. So there are two zones in that. One is the paraaxial zone of 1.5 millimeters, also the one which is most referred to in the Gaussian profile. So when you put this patient on an autorefractometer, when you put him in an IOL master, the refraction that you get is always from the central 1.5 millimeter zone. And in the periphery is the paracentral zone. Now look at this a little more closely. This is an OPD, optical path deviation map from the NIDEC machine, the OPD3. And you can see that in the center, you have an area which is emetropic. And as you go into the periphery, you have a slightly hyperopic zone and a slightly myopic zone here. So as you go into the periphery, spherical aberrations come here. All the pluses denote hyperopia, okay? But remember, this is not a topography map, though it looks like a topography. It's a wavefront map. So where is the wavefront going to come from? It's going to come from the aberrations in the cornea and the crystalline lens. And it's reflected only within the pupil. Look at a case of a myopia, a -1.5 with -1. So there are minuses all around, suggesting that this is the steeper meridian and this is the flatter meridian, exactly opposite of what we see on our traditional topographers. And this is what happens when you correct his best, you put in a spectacle and you make this patient, and you put this patient on the NIDEC machine. You can see that in the periphery, -140, -173. So some amount of positive spherical aberrations always coming once you move even slightly away from the center of the pupil, once you go away from the 1.5 zone. And why is that? That happens because as you go towards the periphery, the angle of incidence increases. As the angle of incidence increases, the angle of refraction increases. Therefore, those rays don't focus on the retina. They come a little in front, and that's the basis of your spherical aberration. Now, here you have a case where this patient, as you can see, is getting early nuclear sclerosis. Because this early nuclear sclerosis, he has this -269, -317, and all in the center. And suddenly this patient who was always using reading glasses, one day comes and says that I can't read anymore. And surprisingly, when you put this patient on the chart, this patient is still reading 6/9 and J2. That is because in the periphery, he has reduced spherical aberrations in very early nuclear sclerosis. And this is the basis and the principle on which we are going to base this. So you have, let's come back to this figure. So if we can increase the hyperopia over here and give this person a little bit of a negative spherical aberration and give him reading vision and keep the paracentral zone for distance, I think you have a winner on hand. So what is the principle of the custom Q? It's to make the central 1.5 millimeter zone hyperprolate to produce a myopic shift, and the spherical aberration should be changed by a value of -0.4 so that you can get a reading correction. So this translates to a delta Q. That means a change in the corneal asphericity. What is the Q value? Is the aspheric quotient. So if you can change the aspheric quotient by about a -0.6, you are able to achieve the hyperprolate only in the central 1.5 zone located on the visual axis. The paracentral zone can then be maintained to achieve sufficient distance correction so that in cases of hyperopia, it would retain sufficient negative spherical aberration. And this leads to better binocular vision. And this shows that at the -0.4 spherical aberration correct, you need to reduce about a -0.6. Now let me give you a clinical example. So this is a case where a patient is an early press bio. He has +175 in the eye, which is dominant, and 2 in the other eye. His asphericity is about -0.2 in both eyes. So how do you plan the correction? You target emetropia in the dominant eye. That means you correct as 1 + 1.5. And you target a -2.5 in the non-dominant eye so that you give reading vision. And the -point Q, you change to a -0.8 because you have to change the delta Q by -0.6. That's all you need to feed into your laser machine. And this can be done on any laser platform, which allows you to customize the Q value in your patient. So this is what you plan, and this is what you get. So what you do is in the dominant eye, you give him a good emetropia. His target refraction is 0, Q -0.Q, and here target refraction -2.5 and -8. So here he gets a little depth of focus in that eye without compromising the distance vision. And these are the profiles of ablation for the non-dominant and the dominant eye. And you can see the results that in the dominant eye, you have a little area of hyperprolateness in the center of the cornea, which corrects as +2.5, and a little more bump in the non-dominant eye, which corrects his near vision profile as well. And there are enough results published in the literature which shows that binocular distance as well as binocular uncorrected near vision are very satisfactory. So in my opinion, what are the indications for Press B LASIK in the 40-45-year-olds? They should be highly motivated patients with clear lenses. They should understand the limitations of the procedure. For emetropia especially, you've got to be very careful. They have to understand that they are going to lose some amount of distance vision. For myopes in whom intraocular procedure are risky, this is the procedure of choice. And suppose you have a young pseudophakic with a monofocal eye. This is something which Sugira was alluding to. If after getting the trifocal or the EDOF in this eye, he wants to improve the depth of focus in this eye where you put a monofocal, you can do this procedure. So contraindications are people with thin corneas or possible keratoconus, previous incisional surgery, or other ocular comorbidities. And what are the results of the Press B LASIK? They are most suited for young hyperopes. Don't hesitate, this will work very well. And if you can stretch that age group 40 to 50, this is something which can definitely work. And central Press B LASIK is preferable to peripheral Press B LASIK. Both are, of course, associated with some loss of vision if you have the entire pupillary zone, but you can think of custom Q to avoid that thing. And basically, if you're looking at myopes and emetropes, the preferred thing would be a Press B Max hybrid. This is dependent on the results that I'm seeing in the literature, Press Beyond and monovision LASIK. And for hyperopes, you should go for supracore, Press B Max symmetric, custom Q, and Press Beyond. So what is finally my personal preference for this age group? Hyperopes, custom Q, as I mentioned so elaborately on the Wavelight EX500, and Prelex in very few select cases. I don't like to do Prelex in this 40 to 45 age group. They still have accommodation, they still have good contrast, they still have a cornea that is evolving, and there is a long way to go at 40. I mean, most people live till 80 now, so I would like to defer that for some age, some point of time. Maybe after 48, 50, I might go in for that. For myopes, I do a monovision LASIK, which seems to work well, and all of us have sufficient experience. As I said, remember the contact lens trial before you do the procedure. And Prelex in a myope, never. I don't think so. It's too risky to go in. And if this fellow develops a PCO and you're going to YAG him and you're going to open a whole, whole box of problems for the posterior segment. And when a hematop comes to me and he asks me for this procedure, I arch my eyebrows, I give a wide smile. Are you serious? That's what I'd ask. Thank you.
Thank you, Sandeep. That was very, very educative.